Okay, to kick it off, I just have a question for all of us. Whether you've been in healthcare for 20 years or 20 months, chances are you've had the very frustrating experience of having an insurance claim being denied by a patient's health plan. Now, many times that denial is for a product or therapy that the payer has previously authorized for other patients that you've had who have similar diagnosis. And even more frustrating, sometimes it's been authorized for the same patient as being denied for this claim. Today's session is designed to better help and equip you with information and tools that understand and work within the reimbursement process for medical nutrition. Please note that today's session will have 3 presenters, and I'd like a brief bio for each of the speakers. Our first speaker is Angela Lively, who's the founder and principal of Lively Consulting, LLC. Angela has 20 plus years of experience in assisting companies to better understand and positively impact healthcare policy changes. Including supporting the launch of dozens of products. She'll be covering the first 2 topics that you see on the screen with a focus on the structure of the HCPCS system and how it's administered by all payer types so you have a better understanding of that process. Angela will be followed by Veronica Nidzinski, an adult cystic fibrosis registered dietitian who lives and works in Denver, Colorado. Veronica has 10 plus years of clinical experience in dietetics, offering expertise in creating individualized care plans using evidence-based and compassionate care to address the nutritional and financial needs of patients and families she works with. In addition to that role, Veronica also participates as an advisory board member and national speaker for multiple healthcare companies on the topics of nutrition and reimbursement. She will discuss the role and importance of medical necessity documentation and how healthcare providers can leverage this information to help payers better evaluate the needs of patients. I will then give an overview of the newly created HCPCS code S9432, Medical Foods for Non-Inborn Errors of Metabolism. In my role as the Vice President of Market Access for Envara Health, I'm responsible for helping to connect patients and their support teams, i.e. you, with payers to authorize appropriate reimbursement for our products. My career in healthcare has included work in the medical nutrition space for Nestle Health Science and Nutricia, as well as working in the health insurance sector for United Healthcare before joining Envara Health in 2020. Lastly, we've left time to hold a Q&A session. Again, please feel free to chat in questions throughout the presentation. With that, I'd like to turn it over to our first speaker, Angela Lively. Next slide, please.
Great, thank you, Chris. I'm so happy to be here, and I'm hoping through the discussion to provide some understanding of the sometimes mysterious ways of the Centers for Medicare and Medicaid Services and their HCPCS coding decisions. It is so exciting to see CMS recognize that payers need a better way to describe medical foods, particularly for those conditions that are non-inborn errors of metabolism, that will allow payers to reconsider, better clarify, and in some cases augment their medical food policies. I look forward to the discussion. Let's go ahead and jump right on into those HCPCS codes. So as you're aware, there are a number of different kinds of codes that are the language of providers. So it's really how providers and payers are able to communicate with each other in a more efficient way, or at least that's the intention of what's supposed to happen, to allow seamless coverage, coding, and reimbursement for medically necessary products, services, and supplies. As Chris mentioned, of course, that doesn't always happen as smoothly as we hope, but that is certainly the intention of the coding system and the continued update of these coding systems. So we'll talk about some of those updates as we go along. I'm hopeful with some effort and some education, some partnering with providers such as yourself, we can improve access to medically necessary medical foods and improving those patients' lives. So let's take a look at the different coding systems, and it is a little bit of an alphabet soup. So I'm just going to provide some context and some explanation of how the structures work, both the overall coding system structure and then more specifically about HCPCS codes. At the top of the screen, you'll see that the first group, the level 1 HCPCS CPT codes, those are the current procedural terminology codes. Those are the codes that describe physician services. So we're not going to really talk too much about those services. That also includes radiological, laboratory services, some of those other type of more procedure services. We're not going to talk too much about those today. We're going to spend most of our time talking about the level 2 HCPCS healthcare common procedure coding system. This is the coding system that's maintained by the Center for Medicare and Medicaid Services, and it's used to describe drugs, biologicals, durable medical equipment, services, and really supplies that are not described by the CPT coding system. This third group on the screen, of course, are the ICD-10 diagnosis codes and procedure codes. These, of course, describe the patient's conditions or procedures performed. The procedures in this case are typically those procedures in the inpatient setting of care. So again, another set that we won't talk too much about. But when it comes to those diagnosis codes, these codes, of course, are used by payers really to translate their payer policies, their coverage policies into codes or claim edits so they can more efficiently process claims when possible. So they are really important, and we will talk a good bit about those, particularly Veronica, as we talk about in the next session more about defining medical necessity, how the policies that payers write are translated into diagnosis codes and how that's connected to medical necessity. Well, let's talk a little bit more about the HCPCS level 2 codes, so we can go on to the next slide. Again, some more alphabet soup, but thought it might be helpful to understand a little bit more about the coding structure of the level 2 HCPCS codes that the Center for Medicare and Medicaid Services manages. HCPCS J codes might be familiar to you as they are fairly common as they describe drugs and biologicals. In particular, drugs and biologics that CMS or Medicare covers when administered incident to a physician service or not self-administered. Another set of these codes, the HCPCS B codes, might also be familiar to you for enteral nutrition tube feeding. Medicare, of course, only covers enteral nutrition when it's medically necessary to administer via a tube. So it's important to understand those unique dynamics because Medicare, when they make their, or CMS, when they make their coding decision, often thinks a little bit more about the Medicare system than in the broader payer system. Consequently, another set of codes have been created over time, referred to as HCPCS S codes. These codes are issued on a quarterly basis and are used primarily by private payers or commercial payers and state Medicaids and Medicaid managed care entities. These are codes to describe items or services that perhaps are non-Medicare, but the commercial payers or state Medicaids may want to cover and pay for. Let's go ahead and move on to talk a little bit more specifically about those HCPCS S codes. As I mentioned, that level 2 HCPCS codes are issued by CMS. And while CMS is really supposed to think about all payers when they make their decisions, they are very specific to they are often very specific to the Medicare program in their thinking. As I mentioned, CMS coding decisions, for example, as it relates to drugs and biologics, are pretty straightforward, and cover HCPCS codes for drugs and biologics, or the enteral nutrition products, as we talked about before. But you may be wondering what happens then when Medicare does not have a need for a code, but commercial payers do. So that sort of sets us up for those discussions of that HCPCS codes. For example, orally administered medical foods such as Encala are not covered by Medicare by some, unfortunately, because of some of the antiquated rules that Medicare has to follow. But so consequently, CMS decided, the HCPCS panel decided that given the payer need to describe some of these additional situations where medical foods are medically necessary, they issued an additional HCPCS code, allowing commercial payers and Medicaid to expand policies beyond just those inborn errors of metabolism that we have become familiar with over the years. On the next slide, this is just a reminder of how this policy continues to evolve for medical foods and how CMS is seeking, the HCPCS panel is seeking to try and keep up with that evolving change in policies for medical foods. There's been a long history of coverage for medical foods, obviously challenging at first, as we had states, sort of a period of time where medical food state mandates were required to prompt coverage of these medical foods. That's where we got the first handful of the HCPCS codes on the right side of the screen that you were probably familiar with, such as the medical foods for inborn errors of metabolism, the modified solid food supplements, and the medical food nutritionally complete, the S9433. However, that did leave out a segment of patients, of course, that medical foods are medically necessary for, however, do not have technically an inborn error of metabolism. The availability of the new HCPCS code that Chris will talk about a little bit later, HCPCS S9432, provides a means for payers to allow coverage for medical foods for non-inborn errors of metabolism, such as cystic fibrosis. I know that presented a lot of confusion about when and where that a payer may cover for cystic fibrosis or medical foods for cystic fibrosis, when technically it is not an inborn error of metabolism. So it kind of depended on how they categorized and what ICD-10 diagnosis codes that they allowed for that coverage. So Veronica is going to talk about some of those dynamics in just a few moments. But suffice it to say, it is always going to be really critical to match up the diagnosis code and to demonstrate the medical necessity of the medical food that you're seeking for a patient. And it's going to take some time to partner with you to educate those payers within the context of their medical policies, so that they have because now they have this new HCPCS code to help better describe when and where it is medically necessary for the use of the product. It is, and one other note on that is, which is sort of just a note on the history of these HCPCS codes. It is very unusual for HCPCS codes to have a reference to the disease state in the descriptor, and so that's where some of the confusion has come up when the descriptor is not necessarily matching up with the HCPCS code descriptor is not necessarily matching up with the ICD-10 diagnosis codes. So we hope in time, as we start to clean those policies up, now that payers have a better way to represent the use of medical food for these different situations with the advent of the new code. To that end, on the next slide, given that long history that I mentioned, there has been a continued evolution of coverage for medical foods and the language used in those policies and how they describe the appropriate use. So I think we'll see a period of time, and we've already started to see an evolution of payers and their coverage policies, as Chris will speak to later. But on this map, you can see that there is a lot of variability of where there are inborn errors of metabolism mandates for medical food, where there are not, how those have gotten applied, who they have applied to, whether it's Medicaid or commercial or both. So there's a lot of variability in policies at this date, and we're continuing to see that evolution. So that's why we thought it would be important to have a bit more of a discussion about the medical policies, how that fits and relates to medical necessity, and how you can kind of partner to improve the odds that we improve coverage and access to medical foods for patients. With that, I will turn it over to my colleague Veronica, who will walk you through sort of analyzing a medical policy and then supporting requests for medical food with medical necessity.
Thank you, Angela. Well, I just wanted to start by taking a moment to define medical necessity, because maybe everybody on the call may not be familiar with the term. And then if you wouldn't mind switching over, thank you. According to Medicare, medical necessity is a healthcare service or supplies needed to diagnose or treat an illness, injury, condition, disease, or its symptoms, and that meet accepted standards of medicine. Now, accepted standards of medicine are based on credible scientific evidence that is published in peer-reviewed medical literature, and it's generally recognized by the relevant medical community, and it's the views of the practicing physicians in that specific clinical area. If we were to use cystic fibrosis as an example, a general pulmonologist may not be as familiar or acquainted with the treatments and standards of cares as a pulmonologist who has worked with the CF patient population closely for many years. Unfortunately, most insurance companies are similar to that general pulmonologist, and they are not specialized in all areas of medicine. And as a result, they require providers to provide additional documentation to support their recommendations. One thing of note, the guidelines that are usually put forth by Medicare when it comes to coverage, this is generally a template that commercial insurances follow and use to create their own policies. Here you can see a side-by-side of Medicare's definition and Cigna's definition for medical necessity. If you take some time to read it, you'll notice that the core message is essentially the same, between the two definitions, but Cigna kind of puts its own spin on the definition of medical necessity, in order to create their policy, and you'll see that oftentimes with many commercial insurances. We can move on to the next slide. Now, if you've worked in healthcare, you've probably seen ICD-10 codes at some point during your career. Like Angela mentioned, ICD-10 codes identify medical diagnoses, and they help insurance companies understand why the care that you are providing for your patient is necessary, and you often want to make sure that you provide them whenever a claim is being filed. Insurance companies will often dictate the coverage for claims by determining which ICD-10 codes they will accept for various procedures. So for example, if we were to use enteral nutrition as the example, if you look at the coverage policy for commercial insurance, they may state that they will cover enteral nutrition for esophageal cancer. So you will want to make sure that when you're writing your note and making sure that you have all of your documentation up to date, you'll want to include that ICD-10 code C15.9 in your documentation. On the right side, you'll see a little square with the different ICD-10 codes that are covered, that cover enteral nutrition. And the top one, C00.0 to C21.8, you'll see the malignant neoplasm of lip, oral cavity, pharynx, and esophagus. So you know that is going to be a covered diagnosis for enteral nutrition. So again, you'll really want to make sure that you include that ICD-10 code in your documentation and in your notes, so that you are able to ensure coverage for your patient. Next slide, please. So I'm going to use the NCALA reimbursement support form as an example. So if you were to order NCALA for your patient, the reimbursement support form is a helpful tool to make sure that you have all the necessary documentation submitted to file a claim. Immediately below the patient information, you'll see the medical necessity support information. And this section has all the documentation that is needed to submit for billing that is listed. Again, using NCALA as the example, in addition to this reimbursement support form, you'll want to make sure that you're providing information such as the front and back of the patient's insurance card, demographic information or face sheets, the letter of medical necessity, and then any relevant clinical notes such as the dietitian note, doctor's note. If you have growth charts for pediatric patients, things like that will be really helpful to support your claim. Again, making sure that you have all this information increases your success for reimbursement. One thing to note, though, depending on what you are trying to get covered for your patient, there may be different needs. So, for example, medical foods may require weight trends, growth charts, while devices for pulmonary treatment may require lung function tests, for example. So if you're tasked with ordering items for your patients at your facility, the company usually they have similar order forms, similar to kind of what you say at Oncala. I know in my experience, when I'm either applying or sending paperwork for my patients to get enteral nutrition or, Relizorb cartridges, they usually have a similar version to this kind of order form. And you'll want to make sure that you identify the medical necessity support information section so that you make sure that you are sending in all the information that is needed in order to get that device covered for your patient. Next slide, please. So when sending in supporting documentation, it is important to make sure that the doctor's and dietitian's note contain any and all relevant information, such as diagnosis codes or ICD-10 codes, any labs or other tests that support the medical necessity. So for example, if we're trying to order Oncala for our patient, adding into your note information like growth charts, weight trends or low BMI, a history of trying and failing other oral supplements, GI intolerance, fat malabsorption, or labs indicating fatty acid deficiency, all that information can help support your case. Another thing that you want to make sure that you send in is the letter of medical necessity. Now, if you've ever written a letter of medical necessity, I feel your pain. I too have, shed quite a few tears writing my own letters of medical necessity. But these are actually very necessary and very helpful to support your case. The letter of medical necessity is a formal written appeal from a physician that that basically supports the need of the patient. Supports the patient's need for a medication, a supplement, a device, or whatever, and it summarizes the treatment rationale. While it may seem laborious to provide so much seemingly redundant information, it is important to provide this to the insurance companies. If we think about this in legal or in court terms, so for any of my fellow fans of Law and Order, if you think about this as a court case, all the information that is in your clinical note, it's essentially evidence, while the letter of medical necessity can be viewed as the polished closing argument. It wraps up all the evidence and the witness testimony, and it kind of puts into a nice little concise package that you give to the jury for them to deliberate over. When it comes to insurance, the unfortunate truth with them is that they will deny a claim in order to not spend money. By presenting them with overwhelming evidence, we make it more difficult for them to poke holes in our case, and they'll be more likely to reimburse the claim. Additionally, if you are pushing for expanded use beyond what is in an insurance company's established policy, your case needs to be even stronger. So when Chris discusses the new HCPCS codes, things like that, in order to have things like that supported and that access expanded, you want to really make sure that you are putting forth all that information to really, make sure the insurance companies understands why this item is needed. Next slide, please. And finally, if you're missing any documentation, this can result in a denial from the insurance companies. Additionally, if you are the person who is tasked with submitting all the documents, or if you're a provider or case manager, it's possible that insurance may bother you multiple times, or if you're working with a company that has a support team that is able to collect all the information and send it in to the insurance company, you might be, bugged by them in order to get more information in order to strengthen that claim. So that takes time out of your day as well. Additionally, not having all the information at one time can delay the patient from receiving either Oncala or whatever item you are trying to order for them. And if the claim is denied, this can incur out-of-pocket costs for the patients. And now, Chris will wrap us up by discussing the new HCPCS codes.
Thank you, Veronica. The objective of this next segment is to provide you with information about the creation of the new HCPCS code S9432, and more importantly, how it will help you and your patients to receive reimbursement. Next slide, please. Okay, so by now, you probably heard that in response to an application submitted by Envara Health, CMS has created S9432, medical foods for non-inborn errors of metabolism. And that HCPCS code was instituted on October 1st of this year. Just a couple things about it. So as you're well aware, if you've been in the industry for a while, a HCPCS code being created for medical nutrition is a very rare occasion. In fact, it's probably been more than a decade since a new HCPCS code was created. So it's big news. And this one specifically has the potential to significantly improve patient access to medical nutrition. I'd just like to cover some of the details about that so you better understand that. So I'm going to start with a couple of details about the HCPCS code. So first of all, many of you are familiar with B codes, the standard codes used for medical nutrition, but you may not have as much experience with S codes. So I want to start with the official definition of the S category. It's actually titled temporary use for commercial payers. However, that nomenclature is actually very misleading in that many of the S codes have been in place for years. Now, as an example, S9435, which many of you are familiar with, that is for medical foods for inborn errors of metabolism, it's actually been in place for more than a decade. So the point here being is that they're not necessarily temporary, they're just not used by all payers. And I'll come back to that in just a minute. Also, in addition to commercial payers using S codes, Medicaid, managed Medicaid, and TRICARE payers also authorize payment under S codes. And again, the best example I can give in this setting is S9435. So essentially, S codes are available to all payer types except for Medicare. And that's a critical point here. From a medical nutrition perspective, it's easiest to think about the S code category, or at least the medical nutrition portion of that, as codes that are applicable to non-Medicare recipients. As Angela covered, CMS created S9432 to enable payers to authorize payment for medical nutrition products that are prescribed for patients who do not have an inborn error metabolism diagnosis. While the code was created in response to an application submitted on behalf of Encala, I do want to point out that S9432 is not product specific. This means that if a durable medical equipment company, a home health infusion company, or specialty pharmacy submits a claim for another product, it is up to the payer to authorize that. It is not a one-to-one product to code. So payers can use S9432 for any medical food product that meets their policy criteria. Now I say that, remember Veronica's explanation of how payers use medical policies to make reimbursement decisions? The key is that the patient meets the medical necessity that matches up to the policy, i.e. the ICD-10 codes, in order to have access to that HCPCS code. Now that's not specific to S9432, that is specific to any HCPCS code that a payer is going to authorize for. So simply put, S9432 enables payers to authorize payment outside of an inborn error metabolism diagnosis. And this is a really key point here, and we're going to get into it on the next slide. And it's actually similar to other HCPCS codes that are created for non-Medicare recipients, like oral and/or pediatric. And in the third bullet point on this slide, you'll see examples of that, B4157, 62, and then also the aforementioned S9435. So let's take a look at how this helps to improve patient access to medical nutrition by moving to the next slide, please. So Angela showed you this map here. I want to repurpose it to go over a couple points in addition to. And I think it's easiest if we start with an orientation to what you're actually looking at. So what this is it's a color-coded map, and probably the easiest place to start is a state where there are no color shading, nor is there a no sign designated. So let's start in the upper left-hand corner. You'll see that Oregon is essentially left blank. So what this means is, through state legislature, there is a mandate that all commercial plans and Medicaid plans, which by the way includes managed Medicaid as well, that all of those plans offered to Oregon residents must have a mandate for authorizing medical foods for inborn errors metabolism. Now that's the good news. So let's go to a different state, and we'll go right above Oregon and Washington. So you see that Washington has no shading either, but also has a no symbol. What this means is that they have the same mandate across those payer types. However, inborn errors of metabolism is either not clearly defined or, like in many states, limited to only metabolic inborn errors of metabolism. So examples of these you're very familiar with, or you may be familiar with, are PKU or MSUD. So the point here is it does not cover all inborn errors of metabolism. So we're going to keep going east, and we're going to take a look at Idaho. So Idaho is one of the unfortunate states that have no mandate for commercial nor Medicaid plans. So essentially, it's up to the payer to decide if they're going to reimburse for inborn errors of metabolism for medical foods. We'll go south a little bit for Nevada. This is an example where a state only has the mandate for commercial plans, but not for Medicaid or managed Medicaid. So obviously that's limiting as well. And to top it off, we're going to move over to, well, let's go over a couple different ones. Let's start in Oklahoma. So the good news for people in Oklahoma is that there is a mandate for Medicaid plans. However, not commercial. But then we're going to jump up to Nebraska, which has the same mandate, but then similar to Washington, has a limit on what they define as an inborn errors of metabolism. So if your head is spinning after all that, please join the group. And it's very difficult and very frustrating to work through. Okay, so I told you that we were going to talk about how S9432 helps to enable payers to work through that. And here's how it happens. So essentially, S9432 is another tool in the toolbox. If we can go back up a couple slides, please. Stay on the map. Okay, thank you. So think of S9432 as another tool in the toolbox to help enable payers to authorize for medical nutrition. So how does that happen? So for this, I'd like to show two examples on how to show that it would help to illustrate that. So let's start with Ohio. So Ohio is a state that's shaded blue, which means that only Medicaid plans are mandated to authorize for inborn error metabolism diagnosis, which obviously is unfortunate for anybody that's on a commercial plan. So the point is, if you have a patient that regardless of their chronic illness or disease or insult to body, if they have fat malabsorption or malabsorption or anything that is designated to receive medical nutrition and get reimbursement for it, your DME, your home infusion company or specialty pharmacy now has a HCPCS code to submit to that insurance plan that is not specific to all the limitations that we just covered across those different states. So simply put, you don't have to have an inborn error metabolism in order to get reimbursement. Now, I do want to point out, it doesn't guarantee reimbursement. We all know that. And I'll also talk about on the next slide how those HCPCS codes actually get listed on payers so that it does enable it. But the point here is that a state mandate is no longer the deciding factor on whether or not a payer can authorize payment for medical nutrition. And that's how S9432 will help to broaden reimbursement across all diagnosis. I want to give you another example here. So we're going to choose Pennsylvania. Okay, so you can see Pennsylvania in the upper right there, and you see that it's no shading with a no symbol. So they have the mandate, but it's limited. And I'm going to use a disease state that we work a lot with, which is cystic fibrosis. And unfortunately, in the state of Pennsylvania, the mandate does not include cystic fibrosis. Again, it's one of those states where, for the majority, it's metabolic inborn errors of metabolism. So if you had a patient and you, as Veronica mentioned, you listened to the ICD-10 code for cystic fibrosis, unfortunately, if a health insurance company is just following the mandate, it will not cover for that. However, that's where S9432 will help the DME and then also the payer to make the decision to authorize for any patient that is medically necessary outside of an inborn error metabolism diagnosis. So next slide, please. Okay, So now we're going to get more into detail about how the HCPCS codes make their way to the payer so that when the claim is submitted, it's actually submitted against a HCPCS code that is already authorized for payment. So on the left-hand side, what you're looking at is an announcement that went out in the beginning of October. And again, given that it's so rare to create a HCPCS code in medical nutrition, EnviroHealth worked with a company, RJ Health, to supplement the CMS communication to payers about the creation of S9432. Now, this communication, which as the payers clicked through, had all the information about the HCPCS code, how CMS created it, what the policies are, and it went to all national, regional, and local health insurance companies. And this was across commercial, Medicaid, managed Medicaid, and also went to TRICARE as well. So beginning on October 1st, payers have started to add S9432 to their approved list, and you see some of the logos of the companies. For the most part, they are national companies like United Healthcare, their community plan, which is all of their managed Medicaid. You see some of the blues that are in there, but also some of the state Medicaids. So in the middle and the top, Indiana Medicaid, on the bottom right, Ohio Medicaid. So the point is that as the communication came out, the majority of payers will add this new HCPCS code onto their approved list of codes that they will reimburse against. Again, this does not guarantee that they will reimburse, but the point is that the avenue is open to the DME. I do want to point out this is not a final list. This is just what we've been able to get as far as information so far. So all of these things will be updated, and obviously the durable medical equipment companies, home health, home infusion, they'll be staying very close to that. So I do want to point out, especially for all the healthcare providers, as you're writing orders, and it's going to be, the claim is going to be submitted under S9432, that due to the innovative nature of a HCPCS code being created for medical nutrition, again, first time in a decade, healthcare providers, DMEs, infusion companies should feel confident of submitting the claims under S9432 for payment, but also be patient with the process of payers authorizing S9432. Again, the process that they're in now is adding the HCPCS codes to their authorized list, and then also matching up the policies that Veronica shared with us earlier. So this concludes our planned presentation, and we'll now move to the Q&A session. So the next slide, please. And I'd like to ask my colleague, Stephanie Katsonis, if we could start off with some of the questions that have been submitted up to this point.
Thank you, Chris. So my first question is going to go to Angela. Angela, one of the questions we received was, why does Medicare not reimburse for oral medical nutrition products?
Yeah, it is sometimes non-intuitive in some of these situations, but unfortunately, Medicare is a somewhat antiquated payer system, and it's based on statute from 1965, and so it's a very defined system that defines what categories of products and services can be covered by the Medicare program. And so unfortunately, medical foods does not hit that category, and a medical food, particularly that is self-administered. And so it's just one of those unfortunate dynamics of how the Medicare program works.
Thank you. Veronica and Chris, do you have any insight or additional adds to that question of why Medicare does not reimburse for oral medical nutrition products?
I know that when it comes to at least enteral nutrition, they want the amount of calories that you receive from the enteral nutrition to be at least 75% or more, to show that you really do need this formula in order to meet your energy needs for the day. If it's anything less than the 75%, the thought process is that you can supplement with food and you can pay out of pocket. And I think it probably translates similarly to the oral nutrition, because oftentimes oral nutrition is seen as supplemental calories. And I think the thought process is they want to make sure that a patient is getting as much nutrition from oral intake, and that these additional supplements can, they don't see it as medically necessary.
And Stephanie, I would add that, well, just a couple of things. First of all, hopefully you're all aware of the Medical Nutrition Equity Act. And actually one of the items of that act is to appeal to CMS to actually reimburse, or excuse me, to Medicare to actually reimburse for oral. So if you're not involved in that initiative, please do look it up. It's really great for the industry. Second, I would say that unfortunately, many payers, they design their policies based off of Medicare guidelines. So you'll find a lot of commercial and Medicaid plans that also do not reimburse for oral. So don't be surprised by that. And then again, as Angela and Veronica mentioned, that's where really strong medical necessity documentation is key to getting reimbursement regardless of the plan.
Thank you. Another question we have coming in, we'll start with Veronica, is you had referenced documentation. What documentation is needed to support medical food for an order to be submitted? Could you review that?
Yeah, absolutely. So with medical food, usually you want to, support the need to, for the patient to gain weight. So things like history of weight trends, if it's a pediatric patient, things like growth charts, BMI, all that information is really good in order to get the product covered. If they have any, inborn errors of metabolism, any sort of labs that can show, low pancreatic elastase or fatty acid deficiency, anything that can support the, the fact that the patient is having this hard time with gaining weight, and that this product will be able to help them in order to achieve a better weight and a healthier weight.
Thank you. Angela and Chris, do you have anything to add on that question around the supporting documentation that would help bolster the case? I'll use that analogy that Veronica had mentioned for the evidence.
I would just add, again, it's just communicating and explaining to the payer the rationale of why the provider decided that it was useful in the first place. To make sure that is presented in a logical fashion, and that the supporting evidence, as Veronica mentioned, like think of it as your kind of case, that you're supporting that evidence of why the provider made that medical decision in the first place.
Thank you. So Angela, I'm going to come back to you. I have another question. It says, sometimes health insurance companies will cover the medical nutrition therapy for some of my patients, but for others with the same diagnoses, they deny that claim. Why are the same patient types treated differently by the same insurance company?
There can be lots of layers going on there. It may be a different plan within that insurance company that it has made different policies, but more than likely it goes back to has all the same information been provided so that they could make the decision based on all of the available evidence. And then the third possibility, of course, is, as we have been talking, the policies right now for medical foods are continuing to evolve. And so you would want to go back and make sure that how the claim was billed and the rationale that you use to support it is consistent with how the payer is thinking about medical food, and that medical foods, and that rationale is provided. Sometimes it can become a process, particularly, hopefully over time, this won't happen as much, but sometimes that can be because a different claims processor reviewed the claim if it was billed with a miscellaneous code. So hopefully over time, as the new code is implemented and policies associated, that there will be more consistency in that circumstance.
Thank you. Veronica, do you have any additional insight into that from your perspective?
No, I think Angela covered it perfectly. Yeah, exactly. It's, differences in plans, and what their coverage is, and also going back to see whether the same information was submitted for both patients.
Great, thank you. And Chris, any insight? I don't want to leave you out, or thoughts?
Just to add that I would assume, as a healthcare provider, I would assume each and every patient of your patients are going to be analyzed differently, unfortunately, because of what Angela mentioned. And that just really, it shows the importance of providing that documentation because it's going to help in the appeals. And just, be patient with your DME as you go through that. They have the same shared goal of making sure that the therapy or the product gets to your patient.
Thank you. And Chris, I have a question for you. It says, can S9432 be used to reimburse for other medical nutrition products outside of Encala?
The answer is yes. And then just as a background for that, typically a payer will not tie a HCPCS code to specific product or products. Now, that being said, CMS actually does tie HCPCS codes to specific products. If you actually go on their site, they have a list of them. But the point here is that, and sorry, I want to back up for a second. I know that we have a mix of healthcare providers and also people from DMEs and specialty pharmacies. So the first thing I would say is, if you're a healthcare provider, try not to worry too much about the HCPCS code, because that is really on the action end of submitting the claim. But just so that you know, when a product is submitted under a specific HCPCS code, sometimes there is a one-to-one relationship. For the majority of S9432, it will not be, again, because the title is Medical Foods for Non-Inborn Errors Metabolism.
Thank you. I have a question for Veronica. Veronica, this one says, have you or other colleagues ever taken part in discussions with insurance companies on behalf of your patient? And if you have, so this is a part 1 and part 2 question. And the second part is, if you have, what are the items or topics to focus on that you focused on to ensure that your patient had the most accurate representation for the therapy that is being requested?
Yeah, absolutely. So myself personally, I've never participated in one of these, but I know several of the physicians that I work with, they will do a peer-to-peer with an insurance company. Essentially, they'll speak with another physician that's employed by the insurance company. And at that point, they'll usually just reiterate all the information that was submitted before, and again, emphasize why the medical necessity for whatever product we are trying to get for that patient. But like I said, I myself have usually just been on the collecting information and submitting it to DMEs or to insurance side, so I don't think we have to deal too much with actual insurance as well.
Thank you. Chris or Angela, do you have any insight into the peer-to-peer discussion that Veronica just referenced of additional information?
I would just add that perhaps, Veronica, you probably haven't been directly involved, but perhaps you helped prepare the information for that engagement with the provider, and so, or the peer-to-peer. And so I would just encourage everyone, if there is a policy available for the product or service, then that you make sure that you review that, and that the physician or provider is aware of the policy. So are they trying to argue for something that's already documented in the policy, or are they trying to educate the provider or the payer about how the policy should be expanded based on whatever medical rationale that there is? It's I guess, important to understand where are they coming from, or where is the starting point that the payer is coming from, so that you meet them and address the questions or concerns that there may be.
Thank you, Angela. This is a question I'm going to put it to all three of you, so I'm not sure who wants to address it first.
We don't have a buzzer.
It says that we prescribe enteral nutrition therapy as a primary treatment for new Crohn's patients. This is their treatment. There's no steroids or biologics, and it's 100% of their intake comes from a liquid nutrition for 12 or more weeks. Could this new HCPCS code help to gain coverage for these patients?
Stephanie, if it's okay, I'll start. I think a couple of different things. I think if it is an enteral, if it's enterally fed, there's other codes that are in the B categories that would be more appropriate, just because I think it's going to be cleaner. S9432 by definition is really for mostly oral intake, and that's the point about non-Medicare recipients. Not to say that it couldn't be submitted under that code. I would use, in this situation, I would use S9432 as a backup to submit the claim. And then I see the follow-up that it is oral. They take it by mouth, not by tube. If that is the case, then I think depending on the payer and their policy of when and where they reimburse for Crohn's, then I do think that S9432 could be used to submit the claim. And at the end of the day, the durable medical equipment company, they're really good at communicating with the payers and inquiring about multiple HCPCS codes at one time. So don't feel like it's a one and a miss. There's definitely other opportunities. I don't know if Angela and/or Veronica has any additional comments.
Yeah, I would say it probably goes back to how the policies have been constructed to see if that is a viable code or not within the context of how that payer is addressing the use of medical foods or that type of use of a medical food, and if it fits within that policy is probably the more important question than the actual code.
And I would definitely tack on to that. Again, depending on what the coverage policy is for that patient's insurance, this could be one of those areas where the expanded access, you might need additional documentation, research articles that have, efficacy data, to support using enteral nutrition may be helpful when you are submitting those claims.
Certainly.
Thank you. And I think we have time for one more question. And this, I'll put this to all three of you because you've all talked about it with the S9432 code being a non-Medicare code. Will this code, do you believe, transition from that to a permanent code? Could I use that word? What are your thoughts? And Chris, I'll start with you. Will this stay in the S category or will it transition as we evolve?
I think it's a great question that we'll have to see. I think ultimately the reason why this will be so helpful for patients is that it broadens the access to it, like we covered in the discussion here today. I do want to point out whether it stays in the S category or not. I really do think that's a nomenclature issue, that it's not really about temporary. It's just about who is it appropriate for. I think if it remains, designed for people that are primarily going to take it by mouth and not be Medicare recipients, it'll probably stay where it is. But if it evolves into something that is tube fed, then I can definitely see it moving into a B category. Angela, do you have more perspective on that?
I entirely agree, and that is sort of an unfortunate dynamic that goes back to how Medicare thinks about these codes, and it goes based on their benefit categories and how they define codes. So I would think in the short term it would stay as an S code. But to Chris's point, I know I'm familiar personally with HCPCS S codes that are more than decades old. So I think the temporary reference is certainly a misnomer. So I think it's here to stay as an S code. The only caveat I would add to that is if Medicare or if Congress intervenes and expands coverage or allows Medicare to cover for an oral medical food, orally administered medical food, then of course, then that would change because that would give rationale for CMS to issue a code that Medicare can adopt on their fee schedules. So I think it's as Chris mentioned, certainly important for everyone to be involved with that advocacy effort as well.
Thank you. That are all the questions that we have right now. So Chris, I'll turn it back over to you.
Yeah, thank you, Stephanie. First of all, I want to thank our speakers today, Angela and Veronica. Thank you very much for your time and your expertise. And just a reminder for everyone, you see on the screen right now, if you want a link to the recording, you can send that to Ann Fitch at afitch@envirahealth.com. In addition, we will be sending out proactive communication to everybody that was registered for this presentation to let you know about the decision on whether or not a CEU was awarded for today's presentation. Otherwise, if you have any questions about the information that was shared today, please do use the information that's on the screen. We'd be happy to answer it. Thank you for your participation and have a great rest of the day.
Great, thank you.
Bye.
Thank you.